Welcome to everyone. Today we are in Verona at ICLO with Dr. Spinu and Dr. Rusu from Romania. Dr. Spinu and Dr. Rusu are two very experienced clinicians and also proofed lecturers. Their main focuses are regenerative dentistry, maxillofacial surgery, and many other things. But please, Dr. Spinu, give to our audience a bit of yourself.
Hello, I'm Dr. Spinu, Alexandru. I'm from Oradea, from Romania. I'm an oral surgery, and my daily practice is about implantology, about bone grafting, and about implants, of course. I like this environment and this kind of courses at the ICLO when we are performing surgeries on human specimens, and we can practice the regenerative dentistry, the sinus lifting, the guided bone regeneration. We can prelevate the autogenous bone, and we can make here a very good job.
Hello, my name is Mihai Rusu. I practice maxillofacial surgery in Romania, in the beautiful city of Sibiu. I would like to say that it's our fourth time here. We are in the Temple of Anatomy and Surgery, where can you learn best what you have to learn, but in a somehow close to real situation. The quality of the specimens here in ICLO ICLO Verona are excellent. So me as a maxillofacial surgeon, I'm helping throughout these courses, organized and imagined by my colleague Alexandru, by showing the anatomical landmarks and especially the danger zones, considering bone grafting, dental implantology, and the reconstruction of soft and hard parts.
So you were helping the trainee during this fantastic course, but let me ask a very straight question. Why even a very skilled clinician should participate in this kind of courses?
I remember being a Syrian that one of my mentors said that the anatomy is learned 99 times and forgot 100 times. So every time that we came to Verona, it was applied remembering of our anatomy, our algorithms of surgery, and repetitio est mater studiorum.
Yes, you can practice and you can go beyond your limits, and you can learn very good in this kind of situation on the human specimen. I think this is the best way to improve yourself and to share our knowledge, and all of the team. We can learn a lot from this kind of experience.
Okay, that's great. So from your perspective, the trainee, which is the skill of the trainee that improved the most after 2 days of training? More anatomical knowledge, or like the techniques, surgical techniques, I don't know, flap passivation for GBI procedures, or anastomy, opening of the window for lateral surgery, which is like the skills that you think the trainee has to keep on after this training?
I think anatomy is a very good point, and of course surgical techniques, they can improve the sinus lifting technique, the GBR technique, the flap passivation, the flap mobilization, lingual flap, buccal flap, about the nerves, the mental nerves, about the mandible nerve. And of course, from lingual flap, they can see the anatomy of sublingual artery, of course.
From my point of view, I was amazed and surprised that some colleagues decided to participate in this kind of courses 2 times in a row. So asking them, why have you chosen to repeat the course? They said that every time that they return from this course, everything seemed clearer, surer, and safer. So it's not about an extraordinary surgery, a huge surgery, but improving the day-to-day basic surgery that every of us are performing at home.
Okay, that's good. That's good. So let me ask a bit more about this training. I know that during this training you run some hands-on session with the trainee on specific surgeries like GBR. I think that yesterday you had a GBR and you are going to have a sinus lift in a short amount of time. So during this hands-on session, you use the UBGEN biomaterials, mainly rebone graft and shelter membranes. May I ask you which was your feeling with this biomaterial and maybe the feedback that you received from your attendants?
Yes, I think the membrane are very good. From BMF, from the fast resorbable membrane, they have elasticity. So the GBR, you can make the very nice GBR. From BMS, from a slow resorbable membrane, you can use to repair the sinus perforation. You can use the BMS, slow resorbable membrane in the sinus, but fast resorbable in a GBR. Of course, the fast resorbable membrane you should very good to stabilize with pins. We are using about 6 to 8 pins, and you can stretch the membrane and you can make a real good guiding bone regeneration, a good bone regeneration. Of course, the bone, for a good result, you should take the autologous bone and mix it with xenograft and to obtain the real regeneration and not only the reconstruction, the bone reconstruction.
So may I have a further question about the bone graft and the autogenous bone, which is the ratio that you suggest for having like a good results, a good regeneration in GBR procedures?
I think 50-50 for 50% autogenous bone and 50% xenograft for horizontal bone grafting, and for vertical you need more autogenous bone, I think 60%. Of course, the clinician should make the very good diagnosis of the and morphology of the defect, and to make the decision tree. What kind of treatment? The lateral bone grafting, the vertical bone grafting, or maybe the contour. If it is a contour bone grafting, you can use it 100% xenograft, 100% UBGEN bone.
Dr. Rusu, do you have like a more it's about the mixing the bone graft and the xenograft, maybe in other type of surgeries?
Yes, I would like to say that what I do like about the porosity of the bone graft is that when we mix it, we are using as well some blood concentrates, and I really enjoy watching the blood flow just creeping through the bone stones and engulfing everything in it. Depending on which type of blood concentrates centrifugate we use, we may use it as a sticky bone, we just may use it simply, but the quality of bone, I would say that it's workable on everyday basics bone.
But you mentioned PRP and EPG, blood derivatives, but I was wondering to ask you if you had the experience of hyaluronic acid in regenerative procedure by like mixing hyaluronic acid with bone graft to enhance the properties of the graft, the regenerative properties of the graft.
If we cannot find the vein, I used a lot. I used the hyaluronic acid from UBGEN, mix it with xenograft and mix it with the autogenous bone, and you get the sticky bone, and it's very useful for sinus lifting and for lateral bone grafting as well. And why not some vertical?
And have you ever tried to also soak the membrane in the hyaluronic acid, like to increase maybe the wettability of the membrane and to like a better chemiotactic effect of the membrane?
I didn't thought about this, but it's a very good point. I will try it.
Next year we will try it. Usually you have a lot of experience about like large surgeries and maxillofacial surgery. I was wanting to know if you have to repair the genitourinary membrane during a sinus lift procedure, which will be the option or the choice of the right membrane to be used in that occasion.
Well, depending on the damage that was done to this membrane, I would say that for a small perforation, just going with the fast resorbing 4 to 5 weeks, I would say that's enough. But if I have to manage a large perforation, I would say that the big membrane, as well with a lot of Schneiderian membrane dissection, would give me a stable result, and I would sleep really good after the surgery, thinking that my reconstruction is going to stay there and is going to keep my implant safe.
That's it's a really good tip for our audience. I was also wanting to ask you, how do you choose between the thickness of membranes? You spoke about slow resorption, fast resorption. But in UBGEN, we have 0.2 millimeters, 0.4 millimeters, 0.8 millimeters, and even 1 millimeter thick membrane, both fast and the slow membranes. Do you have any kind of preference for the less thick and for the more thick, or it is something that you should try first?
I'm using 0.4 millimeters regular for bone grafting, and in a few cases when I want a more stretchable, I can use 0.2. More thinner, it's more stretchable, and I don't need slow resorption membrane to and the fast resorbable membrane, because I need the mesenchymal stem cells from the soft tissue, from the periosteum. That's why I'm using fast resorbable membrane.
Both our cities where we came from are from Transylvania, so we are bloodthirsty surgeons. So I would say that thick membrane is going to be a really serious membrane, stopping, inhibiting the flow cells. Considering that these kind of surgeries sometimes addresses 2 times, 3 times operated patient, I would say that also we have a lot of scarring in our tissues. So operating on a scar tissue, it makes us even more bloodthirsty surgeons. So thin membranes, I would say that they are the option that gives us some idea and cells that are going to penetrate our reconstruction.
Where do you set the limit between resorbable membranes, no resorbable membranes, or even titanium mesh in terms of vertical gain, your GBR?
If I need a real vertical, I should use a non-resorbable membrane. With resorbable, you can use it. You can gain about 2, maximum 3 millimeters of vertical gain, but for a real and very stable regeneration, you need a mesh, non-resorbable mesh. Obviously, it's more invasive. You should remove that membrane, but the quality of the bone is very good and it's stable on long term. This is what I'm thinking. This is my way of doing.
I've got a question related to titanium mesh and membranes. I saw a different publication that titanium mesh are most of the time covered with
so the periosteum,
not also with a resorbable membrane. So in this case, which will be the best membrane? A thick, fast, slow resorbing, or a less thick, fast or slow membrane?
I would say that I would like as well protection for my reconstruction, and as well some penetrability of the local cells. Then again, these kind of surgeries are going to be performed on real serious bone loss. So serious bone loss is going to be in functional places. The titanium reinforced membrane is going to keep our reconstruction in place. The fast resorbable membrane is going to let the cells in. Hopefully our technique of releasing the flaps and our sutures is going to stay there and is not going to allow the oral contamination to destroy our construction.
How important is the flap passivation to not provide like too much tension, not adding tension in the suturing, and how important it is to compact well the bone graft, how much it should be compacted, the bone graft in the surgery. So
I think the flap passivation, this is the key, the most important factor in the surgery. And the flaps should be really passive, and you should close like this. So if it close like this, should never open the flap.
I remember being a resident that I went to a course with a professor from Holland, and the professor used to operate with a few number of sutures, saying that the flap is going to heal between the sutures. But it was this conference was about 20 years ago. The operations that we performed 20 years ago, I would say that are history. So nowadays, considering this kind of cellular understanding of the operation and what we expect from our patient's healing, is going to need sutures that have red tissue to red tissue, the inner tissue, not the pink to pink. So considering these kind of huge reconstructions, as Alexandru said, raising up passivization and sutures that are going to make it tight would be the direction to go for us.
and about how compact should be the bone graft, because sometimes I receive a question about from clinician about should I choose 0.25 1 millimeter granules or 1 to 2 millimeter granules? How much should I compact the graft to have a good healing? So
really compact because the osteoblast will never jump in the gap.
Yeah, and as well, we can expect that some part of the xenograft is going to resorb. So if it is loose from large distances, are going to become huge distances. Talking about the cells, of course. But if you pack it right, if you also bring the autogenous bone, the influx of cells, things are going to be good.
and also, as you said before, the use of the resorbable membrane has to keep the material packed and also provide a lot of stability, because if you are starting to have a moving,
Will never beat bone,
not have a,
and you need bone around the neck of the implant. You don't need bone in the very deep part of the mandible or maxilla. You need bone to stretch it around the volume, the best volume around the neck of the implant.
do you ever challenge the UBGEN products, maybe the membranes, in some very challenging clinical scenario where you said, okay, I will try and I will cross my finger and let's see if it works?
Adică?
As I understand, you say that if we are trying to get to close some huge defects.
Yeah, or maybe if you ever tried the membranes in some clinical scenario where you see it was a borderline choice between no resorbable or resorbable membrane,
Okay.
or if it was in some specific area, I don't know, for instance, in the posterior, where you can have a higher rate of exposure, and if you checked that you didn't have any exposure, or if you had exposure, you didn't have any infection, for instance.
I have one specific case, but not considering the bondable reconstruction, but using a sinus lift. The dimension of left bone was about 1 millimeter from the canine up to the wisdom tooth. So it was maybe a case for zygomatic implant or patient-specific implant. So it was a patient situation that the patient did not afford this kind of product. So we tried to perform a huge sinus lift, mixing the bone, the UBGEN, mixing the autograft, and I had a real nice situation that after 8 months, when I reopened the flap, the inserted implants had stability. I had some bleeding from inside, and after again 6 months, I was a little bit scared. We performed the prosthetic treatment that it was okay. So I'm following this patient for, I don't know, 1 year now.
I think the biggest enemy in regenerative dentistry is infection, and we should be care about neighboring tooth, about the periodontal disease, and I think we can gain a very good result if the patient is clean.
With respect to other key factors, for instance, smoking, bad habits, osteoporosis, which is like the major sources of the greatest enemies of GBR.
It's periodontal disease. It's period disease and active pockets. If the patient has the pocket, we should make a scaling root planning to clean the teeth and to recall to see the patient again and again. If the maintenance, the mouth it's really clean. You can perform the regenerative dentistry. If it's not, it's better to use alternative solution. But the modern world, it's about regenerative dentistry.